Hello, everyone. I'm Larry McNeely, Policy Director at the Primary Care Collaborative, a national nonprofit organization that unifies diverse voices to advocate for better health and well-being for all Americans by strengthening primary care. I'm thrilled to welcome you to today's discussion on strengthening primary care participation in ACOs. A few housekeeping items before we get started. This session, like all PCC webinars, is being recorded. The recording and slides will be posted on our website, thepcc.org, within 48 hours. And you can also find all of PCC's previous webinars on that same website. We'll be taking questions using Zoom's Q&A tool, which is usually found on the bottom of the screen. Panelists will answer questions at the end of the webinar, but please feel free to send questions throughout the entire conversation. Chat has been disabled for viewers, but our team will be providing links to relevant resources throughout the webinar. Also, the PCC is committed to delivering high-quality webinars exploring important topics to primary care and the primary care community, so we'd appreciate it if you took a minute or two after the webinar to fill out our post-webinar survey so that we can ensure that we continue to meet that standard. Now, turning to today's topic, and I am excited about this conversation. Years of evidence has shown that accountable care organizations, or ACOs, often generate more savings and lead to better outcomes for patients in Medicare in particular, as compared to beneficiaries in original Medicare who are not in ACOs. And that same evidence, and that evidence includes data from CMS, 2024 CBO analysis, and PCC's own 2024 evidence report titled The Primary Care, the MVP of MSSP, shows ACOs are even more effective when they're led by or feature a large percentage of primary care physicians as part of that ACO. Yet today, 14.3 million out of around 34 million total enrolled in original Medicare are attributed to ACOs. All this goes a long way to explain why CMS leaders have identified expanding ACO participation as a key strategy for improving the Medicare program. Unfortunately, for a variety of reasons, participation within MSSP by primary care-centric ACOs is waned as a percentage of the program, undermining one of Medicare's most effective tools for keeping people healthy and containing costs. The PCC and its Better Health Now organizational partners have provided recommendations to CMS and in the past on ways to design ACOs and foster stronger participation. And in 2023, we were proud to partner with ACOs, our members, and others to provide input and recommendations that led to the launch of ACO Primary Care Flex, a model focused at the CMMI, focused specifically on primary care delivery within the permanent Medicare Shared Savings Program. While that was an important first step toward strengthening primary care and improving primary care participation in ACOs, there's still considerable work to be done, which brings us to today's discussion on how policymakers can continue to strengthen primary care participation in ACOs, leading to better outcomes for Medicare beneficiaries. With that, I would like to welcome our incredible panel today. Let's see. First, I'd like to introduce Aisha Pittman. Aisha is the Senior Vice President of Government Affairs for the National Association of ACOs. She has 19 years of experience in healthcare payment, alternative payment models, healthcare quality measurement, and health information technology. Next, and we're excited to have her join us, is Dr. Autumn Orser. Autumn is Chief Medical Officer for Carina Health Network in Colorado. She is an innovative physician leader who's been working with FQHCs, federally qualified health centers, in Colorado since 2009 and is a practicing primary care physician herself. I'd like to also introduce Emily Beazold from CMS. Emily is Senior Policy Advisor at the CMS Innovation Center. And finally, I'd like to welcome Meredith Yinger. Meredith is co-model lead of the lead model at the CMS Innovation Center. She is overseeing development and implementation of the lead model and has a background in primary care transformation and advocacy. So, without further ado, then, let's start the conversation. Emily and Meredith, CMS recently announced this new lead model, the next ACO model out of the CMS Innovation Center. Can you tell us a little bit more about that model and how the updated design of this model can actually help strengthen primary care? Excited to learn about that today.
Thanks, Larry. And thank you for having Emily and I. We're very happy to join the PCC today to talk about LEAD and other CMMI models that really have a central primary care focus. So LEAD, I think, and this is actually not exclusive to LEAD, but LEAD is absolutely designed to support and really enable those core primary care functions that primary care practices provide by, for example, providing stability, flexibility, and greater investment in primary care. So, for example, LEAD has a series of prospective payments that it offers, and those allow practices to perhaps invest in care management and care coordination functions that are otherwise challenging to sustain in a fee-for-service environment. And that can allow practices to identify and address chronic diseases earlier on, prevent disease progression, and that in turn enables the ACO to succeed from a total cost of care perspective, right? And by taking on that total accountability for total cost of care in a model like LEAD, primary care practices have the opportunity to share in savings with Medicare. And they can use those savings to then reinvest in core primary care functions or even more enhanced functions, partnerships with community-based organizations, partnerships with specialists, right? And this greater investment, the stability, and then the additional flexibilities that we allow these practices to use when they participate in an ACO model, really sort of hone in on that quarterback role that primary care physicians play, supercharges it, and allows those practices to succeed in an environment that's otherwise really challenging for primary care right now from a sustainability perspective. So let me turn it to Emily. I think she's going to provide some more thoughts on how specific parts of LEAD really support the vision here.
Thanks, Emily.
Yeah, so I just want to highlight a couple of specific policies within LEAD that are new or that build on aspects that we tested in REACH or prior ACO models that I think really are intended to support the primary care community. So Meredith touched on the capitated payments and the enhanced payments, which are additional investments from CMS meant to be put towards those sort of care management, care delivery functions. A couple other things that I would highlight. The first is lower beneficiary alignment minimums. So, taking a step back, one of the requirements for participation in ACO models is having a certain minimum number of Medicare fee-for-service beneficiaries. And we need this to be able to calculate a stable benchmark, stable quality measures, but it can be a real barrier to entry for smaller practices, and that's something that we've recognized. And so in LEAD, we'll be using lower beneficiary alignment minimums for programs that are new to ACO models and also organizations that focus on high needs beneficiaries. So that's the first that's meant to directly address a barrier that we hear about. The next is related to something called voluntary alignment. So there are two ways that patients get aligned to an accountable care organization. The first is through looking at their claims history. So do they have a record of receiving care from this provider? The second is voluntary alignment, where a patient actually signs a form that says, yes, this is my primary care provider, my primary source of care, and you can use that for attribution in an accountable care model. There have historically been a fair number of restrictions around that process. And so LEAD in a couple of ways aims to make that more flexible and responsive. So allowing patients to do that more frequently and have that more frequently reflected in ACO's alignment. Allowing ACOs to have conversations in the patient's home if that's where they're delivering care. And just generally trying to make that a more seamless and responsive process and allow patients to really put their hand up and say, yes, this is my primary care provider and respect that patient choice. And then the third thing I would highlight is new benefit enhancements. So another aspect of accountable care models is sort of waivers and flexibilities where if an organization says, I'm going to take accountability for cost and quality, we say, great, we can waive some of those restrictions that we have in fee-for-service Medicare that are meant to control volume and overutilization because we trust that you're taking accountability. And so LEAD continues to push the envelope on those, and those are things that providers can use to engage patients to help them meet their prevention goals, their health outcomes goals. So just one example that I like to talk about is the medical nutrition therapy waiver. So this is a sort of access to sessions with a clinical nutritionist. In traditional Medicare, it's really limited who's eligible to receive that benefit. But in LEAD, we're testing for ACOs that take on global accountability. Can you expand and offer that benefit to a much larger range of patients with perhaps more mild, so hyperlipidemia and high blood pressure are the conditions that we're expanding that to. So that's just one example of additional tools and flexibilities that you get access to by participating in the model.
Exciting developments. And we hear from primary care clinicians all around the country. First of all, sometimes both that payment system and those administrative requirements stand in the way of delivering what their patients need and what is important to their health. And exciting to see the flexibility, the freedom from some of those fee-for-service restrictions, and also the enhanced, more flexible dollars coming through primary care capitation. So, of course, exciting work building on what's happened in past models from GPDC back to some of the other models at CMMI or CMS Innovation Center. ACO Primary Care Flex introduced one of the first hybrid payment into the Medicare Shared Savings Program, the actual statutory ACO program, and could be a roadmap for future iterations of primary care payment reform. What lessons, and this question really is for both Emily or Aisha, if you want to jump in here, what are we hoping to learn from that particular model, the ACO Primary Care Flex model, and how might that innovation and others help shape the future of the core statutory program, the MSSP, that enrolls, of course, attributed about 12.6 million Medicare beneficiaries this year, this past year.
I'll say what I'm hoping to learn from it, and that's really how total cost of care and outcomes can change and improve with shifting the downstream payment mechanisms and focusing first on primary care. I think PC Flex reflects that while we've had great innovations in the innovation center models with Reach and NextGen before that of having approaches for shifting downstream payment, MSSP has not had that. So this is the first step with PC Flex. We also had some important learnings from the CPC Plus model. So practices that were in CPC Plus and in an ACO were the ones that achieved savings under the CPC Plus model, even though that model overall didn't achieve savings. So we know that when you combine this approach of total cost of care with enhancements to and shifting the payment flow for primary care, you see stronger cost performance and stronger quality outcomes for beneficiaries. So I think the PC Flex model gives us the roadmap to really fully test that within the model. So I think that's what I'm looking for. How do those two things, when combined, lead to enhanced outcomes?
Absolutely. And we want to see that kind of improvement and these kind of pieces spread more broadly. Emily, if you want to hop in, please.
Yeah, no, I think that was really well said. I think really the idea behind PC Flex is, in historical ACO models or in the shared savings program historically, sort of had to wait for that entire performance year to finish up and see shared savings that you'd be able to then take and reinvest in programs. But that's up to a whole year that you're floating additional care delivery investments and activities without any sort of new payment. And that's really challenging, especially for smaller and independent practices. So the innovation in Flex of trying to provide an alternative payment and additional funds up to provide stable monthly investment is I think a really core part of the hypothesis around how do we actually help ACOs have the tools and make the investments to then generate those shared savings on the back end. And just in terms of one of the things that we're keeping an eye on here, it's kind of a partnership between the Innovation Center and the Shared Savings Program, which is under a different part of CMS. But one of the things we're keeping an eye on are those alternative primary care payments actually working their way down from ACOs to the provider organization. So are they passing on those additional investment dollars and they're making their way to folks on the front lines who are actually delivering care to the practices themselves who can use those funds appropriately. So that's one of the things that we're thinking about and keeping an eye on as the model goes forward.
I think one thing I would add, Larry, is PC Flex is helping us understand the on-ramp towards capitation as well, since it's a hybrid payment rather than full capitation that we see in Reach and we'll see in Lead. And so I know NACOs with PCC and AFP, when we were advocating for this model, did a lot of listening sessions with ACOs and practices. And what we heard from the smaller independent practices, the jump to capitation is hard. And so the hybrid payment is an on-ramp. And so I think PC Flex helps us understand what are the necessary on-ramps to get to a full capitated approach.
I appreciate you highlighted that, Aisha. You know, the challenge in in clinical care, as I understand it, is there's no cookie cutter approach to medicine, to actually helping somebody achieve their health goals. And a single cookie cutter approach for transforming payment to support that kind of care isn't necessarily going to work. We've got to have different pathways depending on where practices are starting. And finding a way to help independents as well as those that might be better capitalized to succeed in all these models is a critical priority. I know it's one shared around this table here. So one other piece to throw in the mix here, even as we have the Innovation Center iterating on its ACO models, pushing the envelope of what can happen in payment and investment for population-based ACO models, even as we have tests like PC Flex, there's changes and reforms happening within Medicare's approach to the physician fee schedule, the base method of how we resource primary care. And the advanced primary care management services that were instituted just a couple of years ago, learning from what the Innovation Center has done, we're a real important step towards reducing administrative burden, freeing up some time spent on literally tracking the minutes on some of the care. That is one of the requirements of existing care management codes in the Medicare fee schedule. But providing even practices that don't yet have participation in accountable care, helping them have predictable, stable funding so that they can build out the teams they need to more successfully care for their patients and potentially make practicing within an accountable care model viable for them. How can CMS continue to restructure and refine that APCM construct to foster participation in ACOs? And this one I'll kick to Autumn or Aisha. Maybe you have a perspective.
Yeah, thanks, Larry. I'm happy to start and then Aisha can jump in. We were really excited when APCM came out. It's a great opportunity to think about the patient as a whole and not in that fee-for-service architecture that we were in with CCM. The other thing that APCM did for us is expanded the population that was eligible for those services. And so not just a patient with two or more chronic conditions, but anybody who needed those services could receive them. So it's something that we've been very, very interested in our network. And as you mentioned at the beginning, we work with FQHCs in our network. And so what does that mean? That means that essentially the majority of our patients are at 150% of the poverty level or lower. And then in our MA populations in our Medicare, we're about 50% who are dual eligible for both Medicaid and Medicare. And so as we think through those patients and what their needs are, one of the things that we really want to think about is the social complexity that comes with those patients. When I'm in the exam room with a patient, I can diagnose them and I can put them on a really great treatment plan. But unless I have some wraparound services who are going to make sure that they've got transportation to the pharmacy, a way to pay for their coinsurance when they get to the pharmacy, a system to be able to help them take their medication, especially if they're experiencing homelessness or something along those lines, it's really hard for us to have good outcomes for those patients. APCM is a solution for that. The challenge, though, is that if all you've got are social complexities, you only get $15 a month to take care of those patients. And it could take 2 or 3 hours to really figure out and find a solution for those patients. And so how in APCM do we account for those social complexities to at least an equitable degree that we account for the medical complexities? The other challenge that we've found is that a lot of our health centers who are in rural areas just can't hire people to do APCM for them. It's hard to find MAs just to room patients and nurses to be able to take care of the things that they do. And so how do we find a workforce to really make sure that this is happening in all of our areas? One of the solutions that we found is to do a centralized service and to provide APCM at the ACO level, and that's working relatively well. The only caveat there is that with our payer mix, Medicare Advantage commercial is 10% or less of the payer mix. And so what do we do with our Medicaid patients? How do we get them a similar service so that when the health centers come to me and say, hey, I really want to do this, but how can I do it for the majority of my patients and not just 5 to 10% of them? And that's complex because the states run Medicaid differently. But how do we think about extending this to all patients and not just those covered by Medicare and commercial?
Yeah, I would.
Aisha?
Um, Autumn, you raised some great points in that it creates so much more flexibility than the existing care management codes that are in the fee schedule, and brings a larger beneficiary population into care management. I think with the APCM codes, it's a another lesson of we need various options so that we can meet practices where they are. And so one of the things that we've heard is that use of the APCM codes is really useful and an on-ramp for practices that have not historically been in an ACO. So it's helping them build those capabilities before joining an ACO. So that's sort of one option for the provider practices that have not historically been part of an ACO. And then for those practices that are in an ACO, and Autumn mentioned a great example of this, you really think about your payer mix, your shared services versus services that are specific to a practice and how you want to implement them. And because of that, you then need a variety of different options for payment flow. So that might be APCM, that might be the hybrid payment of PC Flex, that might be more capitation options that we've seen in Reach and Lead. And that's really going to go to what you're doing in your other payer arrangements as well. And so I think APCM just is another great example of how we need a few different options to meet practices where they are as everyone's building these capabilities a little bit differently.
I love that because the as you framed it, Aisha, the practice is making decision based on their patients, but also the coverage those patients have, and maybe another plan in that community is really innovating and doing something exciting. Within traditional Medicare, uh, we if we have a cookie cutter approach, we only have one approach. There's not going to be that kind of flexibility to match the needs of that community. Um, I do want to come back to this question specifically about before I probe a bit more about your experience there, Autumn, at Carina Health. Let's put on the table, Emily and Meredith, some of the interesting steps that the LEAD model is taking and CMS is taking otherwise at the Innovation Center to think about aligning care for dually eligible beneficiaries, for beneficiaries who have that both medical and social complexity, the high needs population, and how you're lining up with what states might be doing. There's some interesting features of this new model.
Yeah, I'm happy to speak to that a little bit, and I'll start with the Medicaid component that you mentioned, which I think really is a novel feature of LEAD and something the Innovation Center is really kind of dipping its toe into for the first time. So the concept here is that for dually eligible beneficiaries, so enrolled in Medicaid and Medicare, there's long been a recognition that there needs to be integration of those benefits and services, but that has typically been handled through managed care. So there are plans and integrated options for beneficiaries who choose to receive their Medicare benefits through an MA plan or managed care option. But for beneficiaries who are still in original Medicare, fee-for-service Medicare, there are not nearly as many initiatives to think about integrating accountability and coordinating across those two benefit streams. And so that's what this component of LEAD is really meant to start to test for the first time. And the idea is that ACOs can be the leverage point for that integration. And so it would be ACOs who are then turning around and establishing partnerships, either with a Medicaid managed care organization in a state that uses those plans, or with the state Medicaid agency in a fee-for-service state. So the partnership is between the ACO and the Medicaid entity, and we will be sort of establishing a basic minimum framework for what those partnerships need to entail and look like. So sharing care coordination and care delivery approaches, potentially risk sharing, But then it'll be up to the ACO to really coordinate that relationship on the Medicaid side. I will say, this is very new for us, I mentioned. So we're sort of taking a pilot approach. We'll be doing a planning phase, selecting 2 states to start where we'll be testing this approach and working with those states to kind of flesh out the details of what that partnership framework looks like. So a lot more still to come here, but something that we're really excited that we're going to be starting to test in this area.
With all the other multi-payer work at the Innovation Center, what's happening in LEAD, your colleagues in the LEAD team, it's really exciting. So let me just then take it back to Autumn and the experience there. PCC's 2024 evidence report that I referenced earlier found that one of the ACOs that's part of Carina Health Network had a particular record that came together to help form Carina Health Network, had a real record of success. Looking just at 2022, which when we did the report was the most recent information, it looks like you combined for more than 10% savings. So the projected cost of that set of beneficiaries in Medicare, traditional Medicare, you came in 10% under. That you had really had high quality scores. And since then, you've continued to make moves, as you discussed, to really embrace APCM. You didn't decide that PC Flex was the right way to go. I'm interested in the insight that some insight for our audience into the choices you made there, and what it's meant, the course you did choose, and what it has meant for the patients you serve in Colorado, knowing that again, this is not necessarily a population of incredibly well-off 66-year-olds with only 0 to 1 chronic conditions. We really had a mix of patients you were seeing in those health centers.
Yeah, we're really excited about the results of the 2024 PCC evidence report. And I think it speaks to the fact that primary care ACOs can do a really incredible job because we focus on getting the patient the right care at the right place by the right provider, and do our best to keep them out of the emergency department, out of the hospital. And we're very careful with how we utilize other resources like specialists, just knowing that a patient might have to take 3 buses to get to the GI doc down in the other part of town. What can I do as a primary care physician to take care of that? And our providers are very careful about how they use those resources. But speaking about what decisions we made, certainly with APCM, that was sort of a no-brainer for us, right? It's very much a value-based care model. It gets away from all of the things that you talked about, having to count minutes and number of times that a patient was reading their RPM or whatever it was, and really just allowed for some flexibility. If the patient needs 5 months from us this month, let's do that. If they need 120 months, let's do that. And still, we're going to get paid the same amount, and that's very predictable. We can do some hiring based on what we know is going to happen over the course of the year. So that was an easy one for us. PC Flex was not an easy decision for us. We spent a lot of time analyzing what we were going to do and what all of the benefits were and what the cost would be to us. And really, ultimately, there were a couple of things. We were excited about it, but ended up not moving forward with PC Flex. Part of that is that PC Flex was a really nice glide path to taking on risk. We're already in the enhanced track of MSSP, and so we've taken on quite a bit of risk already. And so it didn't feel like the right move at that time for us. The other thing that we were concerned about is that it was a CMMI initiative, and as we've experienced recently with making care primary, those can go away depending on the administration's priorities. And so at a time when we were really looking for stability in some unstable landscape, it made sense for us not to do it in order to reduce our operational uncertainty. But certainly excited to see the results of PC Flex as we move forward, and definitely looking forward to learning more about LEAD and what happens there and who the 2 states are that are going to be chosen for that.
No, I think this is all very interesting, and I'm toggling back and forth for a reason here. We've got experience on the ground, real success, And we've got some interesting policy challenges that the team at CMS has been trying to think through. Meredith, I know that one of the interesting things that Emily and Meredith, that the lead model is trying to tackle in a somewhat different way than the prior REACH models and some of what's been happening in the plan universe, is how you deal with that truly high need population. If the core of managing costs and quality over a population is making sure you're targeting services to the acuity of that population, their specific needs. How are you thinking about that with LEAD? What are you trying to test with this new model that goes into that? Honestly, I guess you should tell us when ACOs should apply if they're interested. Share a bit more about that.
Sure, I can start and then Emily can fill in too. I think, one of the primary things we really focused in on with the development of LEAD was incorporating lessons learned from other ACO models, including ACO REACH. And one of the sort of main innovations of ACO REACH was this creation of the high needs track that really provided additional support and flexibilities for ACOs that focused on specifically caring for high needs beneficiaries. And these are beneficiaries who have a more rapidly changing health status, who require a generally very high level of care, and oftentimes, or the more traditional methods for benchmarking and risk adjustment didn't accurately capture the cost of caring for those providers, or I'm sorry, for those patients. And so what REACH did was they implemented this high needs track that uses a concurrent risk adjustment methodology, which is a really technical way to say we look at a patient's more recent diagnoses in order to appropriately estimate the costs that will be required to care for that beneficiary. And we use that to develop the ACO's benchmark. And we also have sort of additional flexibilities like lower alignment minimums for high needs ACOs that are really important for those folks to be able to participate in REACH. And so we've sort of taken those learnings, we've incorporated them in LEAD. I think folks heard us talk about on the model overview webinar that we're incorporating concurrent risk adjustment and lower alignment minimums in LEAD, but we're doing it in a slightly different way where high needs beneficiaries will be incorporated in this unified ACO approach. And so instead of having a separate track that you sort of put your high needs beneficiaries into a different ACO, we're incorporating all types of beneficiaries into one type of ACO and then applying those supports and flexibilities to the beneficiaries themselves. Emily, do you have anything to add that I missed there?
No, I think that was really well said. I think, we're always learning and building from what we've done, even if we didn't exactly get it right the first time. So I think this is an example where we really learned we were trying to be very targeted in supporting these patients. And kind of what we accidentally did was silo them off and force practices to separate their patient panel and treat different aspects of their patient panel differently, or maybe even have to participate in two different models in order to cover their entire Medicare patient panel, which just doesn't make a lot of sense. And so this really streamlines, I think, both for organizations that focus on high needs beneficiaries, that serve a lot of these patients. They still have patients who didn't meet the criteria who were getting left out of an ACO model. So it's a benefit for them that they can now bring in their entire population. Also for lower risk ACOs who still have some of these patients, they now have more supports and resources and more of an incentive to potentially build targeted programs that focus on this population where that might not have made sense under the structure of the REACH model. So I think we really do see this as a core lesson learned that we've been able to improve upon.
And if you watch the progression, the ebb and flow of health condition and a beneficiary's life in the Medicare program, the reality is uh, people don't always start high need. They don't always stay at that very acute level all the time. There's a large portion that do. And the reality is having the ability to have a continual trusted relationship with primary care helps make sure folks don't fall through the cracks. So I see that that's an interesting taking the best of the learnings from the high need ACO track of REACH and incorporating that into a broader population approach. Aisha, you talk to ACO leaders across the country and officials as well. And so you bridge those worlds absolutely in the role that you have there at NACOs. Uh, what can CMS do? We talked 13.4 million folks in ACOs of all types. What can CMS do now to attract and retain more primary care participation in ACOs and help them succeed? Help them succeed in patient care, help them succeed in the program.
Yeah, I'll first do a thanks to Emily and Meredith and their colleagues at the Innovation Center. I think LEAD does a lot of what we've wanted to see in models. The high needs, integrating the high needs track across all ACOs is a great example of one that meets the needs of practices. I think when we look at what we know about LEAD, we're all anxiously awaiting the RFA and more benchmark details. But from what we know, it really thoughtfully brings into the model the best of MSSP and REACH. So I think that is going to have a lot of interest. I know as I talk to our members, everyone is really thinking about what is the potential for this model and how it can help them recruit new practices. I think there's also a strong need. MSSP is still the largest ACO, so to bring innovation into MSSP. I think we really feel like it's time to modernize MSSP. It's been since the 2019 implementation of the Pathways to Success rule, since we had a lot of changes there, and we're ready for some more. And so I think what some of those changes could be are bringing things that we've tested in the Innovation Center models into the permanent program. So things like a stronger voluntary alignment, really liked the alignment approach in REACH. That's something that's been tested that could be brought into MSSP that would drive more beneficiaries into the models. And I think as a result, attract more practices. We like PC Flex because it has that hybrid payment option. We like that you can use the APCM codes as part of while you're in an ACO. But there are practices that are ready to do full capitation and don't have that option in MSSP. And so that would be another great option that has been in the Innovation Center models that we would love to see come into the permanent program. And then there's always sort of the thinking about your budgets. And so there are some challenges with benchmarking approaches. So things like, how do you deal with the ratchet effect when you've been in the program for so long and have to rebase? I know LEAD is addressing that in some ways. What can we do in the MSSP program for folks who choose to remain there? Fraud, waste, and abuse has been a huge challenge for ACOs across all ACO models. So how do we ensure that ACOs aren't being penalized for fraud, waste, and abuse that is occurring outside of their control? Some of those broader programmatic issues will also bring more practices into the ACO model.
And let me just drill in a little bit there. That benchmark question that, and it would love to give Emily and Meredith a chance to talk about this, but for anyone who's not in the weeds, deep in the weeds of benchmarks, there's been this ratchet effect where the way the shared savings program as the permanent program and Innovation Center models have been based on historical spending for any attributed beneficiary population, any set of beneficiaries. And if you do better, your benchmark goes down. So as an ACO, there have been ACOs who've literally left the program, gone back to fee-for-service economics with all of the challenges with it, because those benchmarks have changed. In some cases, they've innovated and moved more in the plan universe. But how did LEAD approach that challenge, Emily and Meredith?
Yeah, I can start and then Meredith should definitely chime in. But with LEAD, the benchmarking approach is really designed to have something for both organizations that have been successful in past accountable care models and are already efficient in generating savings and perhaps are seeing that ratcheting effect, and then also have sort of options for organizations who maybe are new to value-based care, may look, quote unquote, high cost or inefficient because they've been living in a fee for service world for a while. Sometimes those organizations come into a model and really struggle when they're being compared to regional peers because they don't have that experience. So the benchmarking methodology kind of has a bifurcated approach where there's kind of one approach if you're in that category of being kind of high cost and new, and a different if you have been experienced and more efficient. Since you asked about that more efficient side, I can speak to that, and then maybe Meredith can expand on the newer organization approach. But as far as the ratchet effect, we actually are taking some lessons learned here, I think, from SSP in terms of the approach. So, two sort of adjustments to the benchmark that are meant to help mitigate this problem. One is called a prior savings adjustment. So if you've been in a model before and generated savings, you get 50% of those savings up to a certain cap, but 50% of those savings added back into your benchmark. And so it makes that target that you're aiming for easier to hit. It's not just constantly coming down based on what your costs were. And then the other adjustment is something called a regional efficiency adjustment. We've got to work on our naming for things. It's not catchy, but this is for if you are sort of low cost relative to average spending for Medicare beneficiaries in your region, your costs are below the regional average, that you get a portion of that difference between your costs and the regional average, again, added back into your benchmark. So it's not just a pure historical based on your own experience. You get some things that help give you a little bit of cushion and some room to continue generating savings. Meredith, I don't know if you want to add to that or speak to the sort of historically high cost provider piece of it.
Sure. So I think there are a couple of notable things here. One is this idea we've talked about where benchmarks are based on an ACO's own historical expenditures in the base period and then are trended forward, instead of incorporating a regional component or something like that. And so by basing it on an ACO's own expenditures, that makes it easier for an ACO who has higher than its peers spending to come in and achieve savings against its benchmark, right? And can do so more quickly. I think the other thing I would say is that there's an add-on capitated payment that's provided to ACOs that are specifically high spending, so have higher average spending than their region. And that's provided to the ACO as a capitated payment, and it's not recouped and it does not get included in performance year expenditures when we're calculating shared savings. And so what that really means what that really means is that we're giving those new ACOs some additional assistance in sort of establishing themselves, building infrastructure, establishing partnerships across the care continuum to support their success in the model. And then I also would probably be remiss if I didn't say there are a number of other flexibilities that are incorporated for ACOs that are truly new ACOs. And so those look like lowered alignment minimums and a little bit more flexibility in other parts of the model as well. And so there are a lot of components here that very purposefully speak to both providers who've never participated in an ACO before and those who have very, very clearly done so and been successful.
I love that interest in the diversity of the primary care infrastructure. Autumn, you've been an early adopter, so to speak. You've had success in MSSP at the predecessors of the Carina Health Network, where some of those ACOs have been in that program and succeeding. How do we help more ACOs or more folks come together in ACOs in primary care? Because we know that that certainly can help succeed across the care continuum. How do we help folks who are thinking about integrating with their specialty colleagues and leveraging their expertise in patient care? And really, I called out Autumn, but this could be for anyone on the call. Please.
Yeah, that's a great question, Larry. So I think there are a couple of components to that question. One is how do we get more primary care practices into primary care ACOs? And really, I feel strongly that primary care practices should be in primary care ACOs as opposed to some of the mixed ones because there's very dedicated support. There's very good understanding of what their needs are and really meeting them where they are. And a lot of that it comes down to finding out what their pain points are, what the problems are that they're trying to solve, and help them see how an ACO can do that and support them and how they can have access to a network of resources, including peers who are going through similar things. And then the other component, rate that you touched on is how do we get our specialists involved? How do we get the urologist and the nephrologist and our GI folks involved? And I think that's another really important component to it as well. And it really comes down to how do we align incentives? How do we help them understand that they're part of this broader picture of the total cost of care and how important their impact is? And really working with them to help them see how they can benefit from being in an ACO, as well as benefit the populations that are served by them.
I would say, the foundation of ACOs is primary care and then using the ACO to have partnerships across the continuum of care. And so I think we just always need to think about how we keep that foundation at front and center and avoid policies that are going to sort of pit one type of ACO against another. So I would be remiss without pointing out that one of our challenges with PC Flex is that it's limited to low revenue ACOs. And that's essentially excluding independent practices that have chosen to partner with their health system in their community that is leading an ACO. And we just don't fundamentally think that makes sense. ACOs have a number of, or practices have a number of options to consider when they choose to work with a particular ACO. And healthcare is local. That's all going to depend on your region, your area, where you already have strong partnerships. So sort of getting out of the business of micromanaging that partnerships, but then also supporting partnerships. So really like that the Innovation Center has thoughtfully thought about what type of data can we provide to ACOs to help with their engagement with specialists. And then in the lead model, the CMS administered risk arrangements are sort of taking that a step further and seeing how we can support with those arrangements. I think back to sort of your payer alignment approaches, we need a variety of options because a lot of our members are really engaged with their specialists when they're doing risk arrangements with other payers. And so what can we take from those private sector models and pull into the Medicare model?
Appreciate you raising up other models. And I know my colleagues from CMS could jump in, but I am going to have to go to some of the great questions. Some of it's being answered in the chat, or in the Q&A, but Brian Westlake, I believe, asked a question about whether we've tried learning from the Veterans Health Administration's primary care model. And I do want to say that this is a delivery model, but let me call out a couple of features that I know. It's low financial barriers to care for veterans served in that model. It's absolutely team-based care. And third, it absolutely has this sense of whole health where you're pulling down barriers like has happened in LEAD to medical nutrition therapy. You're able to leverage different interventions. Anyone want to react to whether that's a model or those principles are things we should be adapting to innovation center models or the shared savings program?
Larry, I can't really speak to CMMI's sort of overall approach to incorporating learnings from PACT, but I think I'm familiar with the model myself from working in this space. And I think the VA has been really innovative in terms of really honing in on encouraging team-based and whole person care through the PACT model. And I think that that aligns really closely with the goals that we have in LEAD. And so an example of this, right, is we've talked about some of the capitated payment arrangements in LEAD that are meant to both support team-based primary care, provide primary care practices with stability, but also flexibility in how they provide services to their beneficiaries, how those capitated payments include the option to opt into capitation for non-primary care services to really facilitate those partnerships with specialists and folks that we often call preferred providers in the ACO world. And in LEAD in particular, Aisha alluded to the CMS Administered Risk Arrangement Initiative, which we lovingly call CARA internally. And CARA is
Good. It's my wife's name, but spelled differently. So it's
even
not.
better. CARA is both a data sharing and a payment system infrastructure that has really been built to sort of modularly hook on to LEAD and other total cost of care models to incorporate learnings from episode-based risk arrangements that CMMI and other payers have been testing for a long time, and we've seen clear success in those. And incorporating those arrangements and those specialists into the ACO total cost of care framework really supercharge those relationships between primary care and specialists while also removing some of the barriers that exist for ACOs to create these kind of downstream accountable care partnerships by providing the payment and the data sharing infrastructure on the CMS side.
That's exciting and enabling to practices and ACOs of whatever type, and it really ultimately rebounds to patients. Let me pose this question that's in the chat. Do you have any information, Laura Metters asks, any information about how many practices or systems are utilizing the advanced primary care management services? And I'm not asking the Innovation Center folks to bring the latest stats from a separate center at CMS, but it is my understanding that like most care management codes, the uptake starts slow in the first couple of years, and that's where we are. It certainly is a fraction of all those fee-for-service beneficiaries, all those original Medicare beneficiaries with chronic conditions. We know that's the vast majority. And, one barrier that we've heard at PCC is the administrative burden associated with the required cost sharing. If you're not covered by Medicaid or Medigap for Medicare cost sharing, being asked for a $5 copay every month can be a real challenge. I don't know if that's something that your patient populations run into or your clinicians have run into, Autumn, in implementing APCM in your ACOs, but it's something that we're hearing increasingly as a barrier.
Yeah, it really is a barrier. We have so many patients who would benefit from it, and they just don't have the dollars. And it's really about a $20 payment that they would have to make every month to participate in APCM services. And so the ability to waive that for patients who are at a certain federal poverty level or can meet certain criteria would really allow us to provide those services to a greater group of patients.
I
Yeah,
think
I'll
that
just
lets us put in another, if you'll let me squeeze in a good plug for LEAD.
Go ahead, Emma.
In fee for service, there are just sort of statutory restrictions on what CMS can do in terms of waiving cost sharing. But in an accountable care model, we do have the flexibility to do waivers of those types of things. And so that's actually one of the waivers that is in LEAD, was in REACH as well, is the ability to waive cost sharing for certain Part B services. So this would be one of them.
I'm glad
And
you
that's a
spoke up.
great example of a thing that we want to see come into MSSP. So the statutory language is there, but the way it's written in statute is a little restrictive for beneficiary cost sharing in MSSP, and we'd love to see it being more aligned with what REACH has, what LEAD will have to have more flexible cost sharing options in MSSP.
We've talked about all the challenges that LEAD is trying to solve, that we need to solve for the whole swath of the population. How do we reduce administrative burden, change clinician payments so primary care has resources to take care of a whole population? We've talked about affordability barriers to care. This has been such a great conversation. I'm sorry if we didn't get to every question. They were all great ones. I want to thank our guests for joining us today, and say with that, thank you all for a great conversation. Have a wonderful day.